Welcome to the Metastatic Renal Cell Carcinoma Tumor Board at Duke University. This tumor board is brought to you by Pfizer and the National Comprehensive Cancer Network as sponsors. At Duke, I'm Dr. Andrew Armstrong, a medical oncologist. I'll be the moderator of this first tumor board. I'm joined here by my colleagues in medical oncology, radiation oncology, and radiology.
Hi, I'm Dr. Dan George. I'm a medical oncologist and professor of medicine and surgery at Duke.
Hi, I'm Dr. Rajan Gupta from the Department of Radiology at Duke University Medical Center.
Hi, I'm Grace Kim, and I'm assistant professor in the Department of Radiation Oncology.
All right, let's start with this first case. And this is a case of metastatic clear cell kidney cancer. And this is a fairly young man, 58 years old, who presented with increasing hip pain. He was a truck driver and felt pain while he was hauling boxes. And over several months, he consulted with an outside physician and eventually an orthopedic surgeon over his increasing left hip pain. He was found on MRI actually to have a large lytic left iliac wing mass and referred to orthopedic surgery for further evaluation. A CT of his chest, abdomen, pelvis did show a large right renal mass consistent with kidney cancer and a lytic focus in his superior acetabular region of the left iliac bone, which was concerning for metastatic RCC. He also had a small subcarinal node, and we're going to show you some imaging from this case. Dr. Gupta?
Thank you very much. So this is the original CT scan that we see here of the chest, abdomen, and pelvis. And in the upper image, you can see, as denoted by the arrow, a very large heterogeneous appearing renal mass that is hyper-enhancing, and it is most compatible with renal cell carcinoma. On the bottom image, what you can see is the subcarinal lymph node that was referred to, and that measures approximately 2.2 centimeters in its short axis diameter. As we go here, we have another image seeing the same tumor at a different level, and this is really blown up on the bottom there to illustrate some of the different features of this mass. So there are central portions of necrosis inside of this mass, which is the low density areas within it. As we take a look at the bone windows, we can see, as noted by the arrow, the yellow arrow there, that is the lytic mass that is seen inside the left iliac wing. And at this time there, it is beginning to thin the cortex of the bone, but not erode through it.
Okay, so back to the case. This patient underwent a open right radical nephrectomy and repair of the IVC, which was due to several accessory veins being invaded. And his pathologic specimen revealed a fairly large 9 by 9 centimeter right mid-pole clear cell renal cell carcinoma. It was classified as grade 2, had no sarcomatoid features, pathologically staged as a T2 NXM1 tumor. There was no extracapsular spread, but extensive adhesions to the IVC, which required repair and was associated with a great deal of blood loss at the time of surgery. So when he was assessed in our clinic postoperatively, he underwent restaging scans and blood work. His LDH was normal, his hemoglobin was improving, basically up to normal. His left hip pain was mild and relieved by nonsteroidals, and thus radiation was deferred at this point. His functional status was back to really a ECOG of 0 or to 1, and his renal function was now at his new normal of about 1.3. Restaging scans at this point did show, though, progression in his left ilium and the lytic lesion with a soft tissue component. And Dr. Gupta will review this again for us.
So this is a follow-up CT scan that is done, and if we take a look at the top image, we can see that is on bone windows, and we can see that the lesion in the left iliac wing has certainly increased in size from the initial imaging. What the soft tissue component that is being referred to is much better delineated on the soft tissue windows on the bottom of the image, where you can see that the lesion actually goes from the bone, now erodes through the cortex, and actually the high density that is pointed to by the arrow is actually showing where there's soft tissue tumor extending from the bone into the soft tissues adjacent.
Great, thank you. So at this point, I'm going to pose 4 questions for my expert discussant, Dr. Dan George. Number 1 is, what do you consider in 2016 to be the optimal frontline management strategy for this kind of patient who is considered good risk, has really 2 sites of metastatic disease at this point, a solitary bone metastasis, really minimally symptomatic, and a lymph node metastasis?
Yeah, Andy, this is a great question. This is a scenario that is not uncommon, unfortunately, for renal cell carcinoma. We don't screen typically for this cancer, and so probably about a quarter of patients will present with metastatic disease, as this gentleman did. And yet he's still got a relatively low volume disease at this point in time. He's only got a couple of sites of disease. His primary tumor is out. He's got a good performance status. The first thing we typically do for cases like this is we'll do something called risk stratification. And there's a couple of different scales we can use. Historically, the Memorial Sloan Kettering Cancer Center scale is what we've used. It includes five factors, including elevated LDH, which he didn't have, anemia, which he does have, a little bit of anemia, a decreased performance status of ECOG 2 or less or worse, and he's clearly not that. A presence of his primary tumor in place, an elevated calcium, or instead of the presence of primary tumor, the time to systemic therapy. So the fact that he's presenting with metastatic disease that's mildly symptomatic, that's progressive in this time point, we're going to start systemic therapy within a year of his diagnosis. And the fact that he's got some anemia, although it's mild, gives him sort of two risk factors, two poor risk factors, and that makes him an intermediate risk patient. So even though I think on the surface, this is a gentleman who has kind of, low volume disease, I am a little bit concerned about the fact he's got a couple of risk factors, and he's got this bony lesion that is in his pelvis and has caused some appearance of destruction. So one option for somebody like this would be to start with systemic therapy. Another option would be to palliate that, even though it's mildly symptomatic, that bone lesion with some form of radiation therapy to treat that. And Dr. Kim, do you want to comment on that before I talk about the systemic therapy? What's the role for radiation therapy in terms of palliation for a case like this?
Mm-hmm. So radiation therapy is very effective in palliating pain, especially if we catch it earlier on, if it's a smaller lesion. I would say that the pain control, if you look at all studies, is somewhere around 80%. Now that's complete response and partial response lumped into that group. Of course, a smaller number have complete pain response, but a lot of times we're able to knock down the pain medicine a notch or two, which is very helpful in terms of quality of life. Now, something in the pelvis, we also want to be maybe more aggressive because it's a weight-bearing bone, and so that can also affect quality of life. Usually, radiation is very well tolerated because it's a focused beam, especially when we target bone and muscle. There's not symptoms like nausea or diarrhea. Sometimes patients have fatigue, but for the most part, it's very well tolerated. And so I think it's depending on how fast they need to get to systemic chemotherapy, we could do anywhere from 1 to 5 to 10 treatments, depending on their performance status, depending on the durability of response that we want to achieve. So if somebody wants, if we're expecting this person to live a long time, then we would choose 10, because in studies we see that 10 treatments, although equivalent to pain relief to one treatment, the need for retreatment is higher in the one fraction.
Sure. And this patient being intermediate risk, but with good performance status, young and with overall low volume of disease, we'd expect him to live probably close to 2.5 years on average, with some patients living much longer than that. So certainly, I think a more definitive course would be reasonable. From a systemic therapy standpoint, he's really got sort of two options. Traditionally for patients like this, we'd consider a high-dose IL-2 therapy as an option. Now, that's not necessarily for all renal cell carcinoma patients. For our patients that are over 70, we worry about the cardiovascular strain in that population, and the risk of complications goes way up. So we generally think of that for a little bit younger patient population, and certainly a healthy patient population. But he has no cardiac risk factors that we know of at this point. He's somebody that is young and good performance status. So I would consider him a candidate for high-dose IL-2 therapy. And the other advantage there is that if he does have some progression, particularly if we're able to kind of control that pelvic disease, then that lymph node disease or other sites of disease, even if that progresses, it's unlikely in that sort of 3-month window of time that we would give the high-dose IL-2 and look for a response, that the progression would get out of hand. So that would be an option for him. alternative option would be treatment with a VEGF receptor tyrosine kinase inhibitor like sunitinib or pazopanib. And these are standard therapies now. They're available, widely used, been around for a number of years, and have a higher response rate than high-dose IL-2, which traditionally has a response rate probably somewhere around 15 to 25% partial response rate, but maybe only a 5% or less complete response rate. For the VEGF receptor TKIs, the response rates are probably closer to somewhere around 30 to 40% in some cases for partial responses, and for stable disease, another 30 or 40%. So the majority of patients showing at least some degree of tumor regression, some minor responses or whatnot. So that's an attractive option for many patients as well, because it has overall a higher likelihood of controlling disease up front, and two, because it seems to be tolerated in a wider population of patients. Does have its degree of side effects, but it's also active following high-dose IL-2. So for a patient like this that chooses high-dose IL-2, it can be that he can go then on to a VEGF receptor tyrosine kinase inhibitor after that. So the way I present this to patients is typically, if you're going to do that high-dose IL-2 therapy, let's do it up front. If we think that it's a reasonably safe window to try that in. And if it doesn't work, we still have this VEGF receptor tyrosine kinase strategy to try. If this isn't something that they want to put themselves through, or we're concerned about risk, or we're concerned about rapid progression or more symptomatic disease, then we'll start with that VEGF receptor TKI up front.
Great, thanks, Dan. I think that addresses questions 1 and 3, but how about number 2? So what trials would you consider 2016, 2017 to be the most important in this frontline setting and that may change the standard of care in the future? What would you be looking for a guy like this?
Yeah, there's several trials that I think this year have been real paradigm shifts for the field. And of course, we don't know the results of these yet, but I say paradigm shifts because it's really paradigm challenging studies where we're really looking at immunotherapies, novel immunotherapies, not high-dose IL-2, but newer, more targeted immunotherapies, either combined with VEGF targeted strategies or against VEGF targeted strategies. And well, one of these includes the study of ipilimumab and nivolumab versus sunitinib. Now that study is just closed to accrue, and we're waiting the results, but that's been a recent study, and we look forward to seeing if there's a population of patients or if all patients in general benefit from that upfront use of ipilimumab, nivolumab instead of a VEGF receptor tyrosine kinase inhibitor. A second study is looking at the use of Avastin and atezolizumab, a PD-L1 inhibitor, in combination versus sunitinib. And so that strategy there combines a VEGF inhibition with a PD-L1 inhibition, and seeing if that's better than the traditional VEGF receptor TKI. And then a third strategy is looking at a vaccine, a dendritic cell vaccine made by the patient's own nephrectomy tumor, and then that's used to create RNA from the tumor to create a dendritic cell vaccine to stimulate the immune system in the setting of standard of care sunitinib or pazopanib, and again compared to sunitinib or pazopanib alone as standard of care. So again, 3 strategies involving immunotherapy in comparison to standard VEGF receptor TKI.
Great, and the final point is, we've all heard about asymptomatic brain metastases, and the question is, when would you scan a patient with kidney cancer's brain, CT, MRI? Would you consider that in this case?
This can be a challenge. I generally do consider, especially before embarking on something like high-dose interleukin-2 or a clinical trial, that some kind of CNS monitoring is warranted because we can find asymptomatic lesions in these patients, and when we find them asymptomatically, they're easier to treat, and they can be unifocal, and that can have a better prognosis. Problem is, sometimes insurance will deny that if it's not a symptom-driven indication. So that's something we do, our peer-to-peer consultations on. I think we all challenge with that, but it's something in general I think is worth considering in most patients.
So he actually had CNS imaging that was normal at the time, and he elected to go with what you described as IL-2, and high-dose IL-2 is administered in the hospital. He actually got 10 doses in his first cycle. This was limited by pretty severe diarrhea, some hallucinations. The second cycle 1B, he got 7, and now this was limited by low blood pressure, diarrhea, itching, somnolence, pretty standard. And he had stable disease after his first course. He actually got all the way through cycles 3A and 3B, did pretty well with prolonged stable disease. And at that point, he wasn't able to get much more high-dose IL-2 because of intolerance, and we simply observed him off therapy. Now, he didn't have a partial remission other than in his mediastinum, which disappeared. His lytic lesion remained stable. So he had, kind of a mixed, stable disease, but symptomatically he was improved, and we elected to observe him. Now, about a year later, now off of all therapy, he developed some increasing neck and headaches, and he had an MRI which showed a new right cerebellar brain metastasis, 2.3 centimeters, and Dr. Gupta will show us this.
So this is the MRI of the brain, and we have 2 images here. And the first image demonstrates this large, isolated right cerebellar hemisphere met that has some pretty characteristic features of a bleeding lesion, in that it has this hemosiderin rim of black or dark hypointensity around it. And then also it has these waves of high signal surrounding it on the T2 weighted FLAIR image there, and that basically is some edema. And then when we take a look at the other image on the other side, what we can see here is very bright contrast enhancement on the axial T1 post-contrast image. It's very compatible with what you'd expect to see in the setting of a metastatic renal cell carcinoma to the cerebellar hemisphere.
So let me start with Dr. Kim here. He's in the hospital, symptomatic. This is a fairly sizable tumor in a difficult region. Would you, as a radiation oncologist, recommend stereotactic radiation to this lesion, or would you suggest that the neurosurgical colleagues get involved?
I would talk to neurosurgery about this case. Anytime there's a solitary lesion that is sizable, not like 2 millimeters, but something like this, anytime there's any kind of edema, mass effect, we always want to consult our neurosurgery colleagues to take care of this.
Great. And fortunately, they agreed with you, and he was admitted, placed on some steroids. He went to surgery right away, actually, and had a full margin negative resection. It was clear cell renal cell, and he got SRS to the bed post-operatively and did quite well with this, actually. Systemically, he was free of disease other than a stable lytic lesion in his left iliac. So Dan, let's go back to you again. So after failure of IL-2 now, even though he's not officially on it, he got his 3 courses, progressed with an isolated CNS metastasis, but still has some disease outside of his brain. What would you do at this point? Do you feel like the radiation was necessary, for a completely resected brain metastasis? Would you consider whole brain radiation? And how would you image his brain from now on?
Yeah, this is a challenging case because, he doesn't really have measurable disease for us to judge his systemic therapy and whether or not it's working. And as I mentioned earlier, our VEGF receptor TKIs, they have some side effects. They can cause, fatigue and high blood pressure and GI symptoms, and they don't work 100% of the time. So it's nice to be able to have some measurable disease to see that we're really having a positive impact on the patient, even if it's just stable disease in that setting, versus, and to put up with the additional side effects that they'd have. But this case is different because this case had a known metastatic progression in the brain resected. And we would be concerned that there could be other sites of disease in the brain or other parts of the body that would occur in the near future. So one option is to do whole brain radiation to kind of protect that, try to treat that microscopic, if you will, other sites of disease before they get bigger. The other option would be use a drug like sunitinib or pazopanib to try to change the blood flow in the brain in a way that might alter that tumor vasculature and prevent that kind of progression in the future. And I generally, for a patient with a single lesion like this, prefer the systemic therapy first. Because I think it still keeps open the salvage radiation option later. And it is something that we're worried about progression, not just in the brain, but elsewhere. And we do know that these drugs can penetrate the blood-brain barrier and get in there and prevent that kind of a site of disease and show response in the brain as well as other organs. So I feel pretty comfortable that, that would suffice in a case like this. So for me, I would probably start this patient on a VEGF receptor TKI.
Great. And you'd image his CNS along with restaging scans along the way?
Absolutely. Especially where he's had this lesion now, he'll be at risk for either recurrence or for new lesions in that organ.
So that's exactly what we did, and over 6 years ago, he was started on the typical 4 and 2 schedule of sunitinib. He achieved a near complete remission. He had a little bit of sclerosis in his left hip, but his soft tissue components in his chest disappeared. He was put on denosumab as an agent as anti-resorptive therapy to improve his bone density and reduce his risk of fracture. He did have some difficulties with sunitinib at this full dose and schedule. Really around year 3 or 4 it became even more challenging, diarrhea, fatigue, and we switched him to the 2 and 1 schedule, and he actually remained in a near CR for an additional 2 years. So this is about 6 years of a VEGF TKI. So he did quite well, and he actually developed some other medical complications really unrelated to his kidney cancer, an aspiration pneumonia. And because of this, we actually had to stop his sunitinib. He was in a near CR, and the discussion came up about, does he really need this drug anymore? So this is a little bit of an unusual circumstance, but let me just ask you your experience. In a patient who's doing so well, have you actually stopped sunitinib, and what's been your experience with that?
Yeah, this is a really great response and duration of response, and very fortunate for this case. It's not typical for sunitinib, but we do see it. And in fact, there's been some nice literature out of France, a kind of a retrospective collective that has sort of categorized a number of complete responses, either with drug alone or drug plus focal therapy. And the results are interesting because about half of the patients in those scenarios actually did take a treatment break, and about half of those patients relapsed, and about half hadn't as of about 2 years. So there is a proportion of these patients that we can stop systemic therapy on, and they don't at least immediately recur. I can't say that that's cure, but I can say that there is sort of durable disease control in a number of these patients. So it's a very reasonable thing to do, particularly in somebody that's having other medical complications.
Right. So he actually, about 8 months after stopping the sunitinib, developed increasing pain and disease progression. This was about a year ago, and sunitinib was restarted, and he actually subsequently responded to therapy. So jumping to the final question is, let's say this patient now in 2016 progresses on sunitinib. What would be your 2016 standard of care following a frontline VEGF TKI?
Yeah, this is very challenging because, again, this is an outlier case. This is a guy that's responded now for 5 years now to VEGF receptor tyrosine kinase therapy. And it wouldn't be unreasonable to say, geez, he did so well on this one, could we try another one? But just in the last 3 months now, we have a new FDA approval in this space with a drug called nivolumab, a PD-1 inhibitor, that has demonstrated a real survival advantage, not against VEGF receptor TKI, but against an mTOR inhibitor, everolimus. But the overall survival associated with that agent was very, very impressive. It was almost 2 years, or a little over 2 years, median overall survival. And it's impressive as well because we didn't see a change really in the progression-free survival. Median progression-free survival is around 4 to 5 months for both everolimus as well as for nivolumab. And yet we see this dramatic difference in improved overall survival associated with this. So to me that says that treating with a immunotherapy next, like nivolumab, even if it doesn't show a partial response, which 20% of patients did and have a really sustained duration of response in that scenario, that very well could happen. But even if that doesn't happen, if they end up with some progression over the next 4 or 5 months, that's a patient that's still likely to live for another couple years and very well could respond again to our VEGF receptor tyrosine kinase strategy. So to me, this is another sort of ideal circumstance where we might try an agent like that. And again, what we're looking for is any kind of, sure, we'd love to see a partial response, but even stable disease to kind of keep that therapy going. But know that they can, respond and benefit to subsequent therapy after that.
Great. So that's my final question, and that concludes our first tumor board here at Duke University. Thanks for joining us.